Hello, everyone. Welcome to the symposium, Delineating the Brain-Muscle Crosstalk for Disability and Dementia Prevention. My name is Hidenori Arai, the president of the National Center for Geriatrics and Gerontology, Japan. Brain-muscle crosstalk is getting a lot of attention today because of the strong relationship between cognitive decline and sarcopenia in older people. Based on our observational study delineating the link between the brain and muscle, we have proposed physiocognitive decline syndrome, PCDS, which is a clinical phenotype of concurrent physical frailty and cognitive impairment, and is a high risk for dementia and disability. Today, we have three excellent speakers on this topic, two from Taiwan and one from Japan. Please enjoy the talks, and we can discuss later. Thank you for your participation.
Hello, this is Dr. Langong Chen from Taiwan. My topic is physiocognitive decline syndrome, phenotype and treatment target for unhealthy aging. In 2015, WHO published the World Report on Aging and Health, which defines healthy aging as the process of developing and maintaining functional ability in a life course that ensures well-being in the older age. That is a very important transformation in healthcare service, so that we move from disease-centric model to function-centric model in the health of older people. Then in 2017, WHO published the Integrated Care for Older People that clearly defined 5 elements for intrinsic capacity, which are mobility, cognition, psychological, sensory, and vitality. And in 2020, the WHO kicked off the 10-year action plans for the decade of healthy aging. That is the global action so that we can promote healthy aging to enable older people getting much better quality of life and well-being in their older age. And the most important and biggest changes in the healthcare service is moving from the disease-based model to the function-based model. That is a very important move. So when we talk about healthy longevity, because longevity is very common nowadays, everybody will live much longer as you expected. And we're hoping the extra years will be of good quality of life and good health and with good meaningful years in your later life. So nowadays, people are hoping to compress the years of disability or mobility. We don't really care so much about the lifespan, but most important thing, people are hoping to maximize the health span. So to shorten the days being dependent, needing care services. So health is not just for all, health has to be longer as well. So based on those ideas, we think we have to reevaluate the aging process and the functional trajectory in the life course. So if we start from the end of the life, that maybe the worst outcomes will be the disability and mortality. So if you're doing physical health, you would say people start to getting older starting from the physical health. That is from robust to frailty and frailty, then move to disability and mortality. But if you're doing dementia research, you would say people start to get older from the normal cognition, mild cognitive impairment, and dementia. But eventually, in the real life, all those different categories are mixed together. They are very strong interactions. It's very few cases that only presented simply in physical health or in cognitive health. Eventually, they are quite mixed. So why is that important? We categorize or to differentiate the different trajectory towards the adverse endpoints of life. Because with different trajectory, we may come out with different treatment so that to get the best outcomes in the life course. So it is the spirit of the precision medicine. So in this figure, you can see if you focus on physical function decline, then you can develop treatment A. But if you focus on cognitive function decline, you may develop treatment B. But for those who has both conditions, you may develop treatment C. And treatment A may not be effective in the people who needs treatment C. So that is the concept that we need to differentiate the functional trajectory in the life course. So in the epidemiology, we can see that when people are getting older, the prevalence of frailty is getting higher year by year. On the other hand, the MMSE score is dropping year by year as people getting older. And with these trends, you can see there are multiple different combination subgroups for the physical function and the cognitive function. And those subgroups, they have different prognosis, they have different survival risk. So this is highly compatible with our previous observation and the concept in the functional trajectory in the aging process. And studies have shown that physical frailty already become a strong risk factor for dementia of all types. So both physical function and cognitive function are highly interrelated. So we're thinking whether those declining trend is just a coincidence or there is a stronger consequent relationship or even stronger causality relationship. We're not the first group to come up with this idea. IAGG defined cognitive frailty to describe that situation. So in the IAGG definition, cognitive frailty is the simultaneous presence of both physical frailty and cognitive impairment. In the operational definition, they use the physical frailty, which is 3 out of 5 of the physical frailty criteria defined by Linda Frey. And the cognitive impairment is MCI, that is CDR equals to 0.5. So that definition is a conceptual proposal, but there is some worry about this definition because the prevalence may be a little bit low based on the previous finding in the epidemiology. And some study trying to evaluate whether this is a good definition using different operational definition to capture this phenomenon in terms of predicting further cognitive impairment. And the result turned out to be that the best prediction model for the cognitive decline is slowness plus MoCA-defined cognitive impairment instead of physical frailty and the MCI. So this is the first paper trying to examine whether the cognitive frailty is a good operational definition for this condition. So people trying to modify the diagnosis of cognitive frailty using the reversible cognitive frailty and the potentially reversible cognitive frailty. So first thing, in the physical part, they're using the physical pre-frailty and frailty, not just frailty. And in the cognitive part, if you use MCI, and that is a potentially reversible cognitive frailty, but if you use the SCD, subjective cognitive decline, that is the reversible cognitive frailty. So that to pick up early enough cases for the risk of unhealthy aging. But the question is, the previous study have shown that SCD has been strongly influenced by depressive mood and a lot of psychosocial factors. So we're thinking maybe we still need some objective measurement for the cognitive performance instead of SCD. So all those definitions are trying to capture people who meet the criteria for unhealthy aging, that is having impaired or declining trend in their physical function and cognitive function. We use our cohort data and the latent class analysis trying to see whether there are some special subtypes in the physical frailty. And the result was yes, that there are 2 major subtypes. One is mobility frailty, another is non-mobility frailty. Mobility frailty is featured by the clustering of slowness and weakness, and the non-mobility is the clustering of fatigue and unintentional weight loss. The mobility frailty subjects are older, thinner, and weaker. They're having low muscle mass and bone mass, and they're having more multimobility. They're having poor cognitive performance, and most important of all, they have higher mortality risk. And for the non-mobility frailty, they're thinner and bigger, having higher cardiometabolic risk and have more depressive symptoms. So the mobility frailty may be related to neuromusculoskeletal system, and the non-mobility frailty may be the cardiometabolic and mood disorder. This finding has been further validated by a Japanese cohort from the NCGG, and we found that in the 10-year follow-up, that in the beginning stages, people are robust in both physical and cognitive function. They gradually developed mobility frailty and non-mobility frailty. And using the group-based trajectory modeling, we also found similar trends for the people who are getting older in the 10-year follow-up. So this is something really happened in the aging process using the different countries' cohort to examine the hypothesis. And also some other studies from the Western countries, they also indicated that not in terms of the cognitive risk, not all components of physical frailty are the same. Only slowness, weakness, and weight loss can predict cognitive declines, but not others. That is highly compatible with our previous finding. That strengthens our idea to have a new definition for that phenomenon. So we're trying to develop a new operational definition to capture this feature. So we modify and redefine the operational definition and named it as the Physio-Cognitive Decline Syndrome, PCDS. In defining the PCDS, the biggest and the highly prioritized goal is the reversibility. So hoping to identify people who are at risk and early enough for intervention, so that to promote healthy aging. So our diagnosis in physical part, mind, mobility impairment, no disability, we use only slowness and or weakness. In the cognitive part, sight, cognitive impairment, no dementia, we use the 1.5 SD and of the age, sex, education match norm in any domain of the cognitive performance. And we're hoping to identify people who are at risk for mortality, disability, and dementia. So we're using the cohort from Taiwan to identify PCDS, and we did find that the PCDS has a stronger risk for all-cause mortality and cardiovascular mortality. In the Japanese cohort, and the result shows that PCDS was highly predictive for incident disability and incident dementia. So in the epidemiological study, it meets all our idea that PCDS is an unhealthy aging phenotype. And in the 8-year follow-up, what about their transition? Sometimes basically PCDS is a progressive condition. When people are getting older, and less people can remain in robust, but still sometimes people can have some different transitions from robust to mild or sign, or those who has mind to become robust. But generally speaking, as people are getting older, so it is a progressive condition of PCDS. So overall, based on the epidemiological study, we know that there are approximately 10 to 20% of community living older people who have PCDS, and they are at risk for mortality, incident disability, and incident dementia. So we use the brain imaging of our cohort to try to see what is the underlying neuroimaging findings, the biosignatures for PCDS. And we did find some age-related gray matter volume deficit of the PCDS. So if you look at the upper row, that is the control, that's healthy people. And in the middle row is the mid-age PCDS cases, and the lower row is the older PCDS cases. And you can see, especially in the older PCDS cases, there are some gray matter deficits, especially in the cerebellum, hippocampus, limbic system, especially the amygdala. That is very important finding because that echoes our findings in the phenotypes. But the question is, the three different regions are very distant in the brain in the neuroimaging consideration. And we're trying to find out if there's any neural circuit, try linking them all together so that it is a potential mechanism to trigger the gray matter deficit of the three different regions of interest. And using the DTI technology, we define a new neural circuit linking cerebellum, hippocampus, and amygdala. So that could be a potential biosignature for the PCDS in terms of neuroimaging. And in the basic researches, we're trying to find out whether the atrophic skeletal muscles have some adverse impact on the neurons compared to from CNS to the muscle. So we're using the animal study and some cell line study. We did identify that in atrophic skeletal muscle, there will be some exosomes being secreted into the circulation. And among all the exosomes, especially those who contains microRNA 29B3P, that in the circulation at the end, it will trigger the senescence and stop the development of the human neurons in the iPS-based eye neuron study platforms. So this implied that people are not doing exercise who have a physical frailty and some having sarcopenia, eventually from periphery, the skeletal muscle can have adverse impact to the neuron. So traditionally, we think muscle is influenced by the CNS, PNS, and neuromuscular junction. And the skeletal muscle will feed back to the brain through the proprioceptor and the streptoreceptor receptor. But now, through the circulation, there's a new biomarker, miR29B3P. So that links muscle to the brain. So the brain-muscle axis or the crosstalk may be a new hypothesis and the potential pathway in the unhealthy aging. So what about the reversibility? So we use a subsample of a nationwide cluster randomized control trial to see whether PCDS is a reversible condition. So this is overall we have over 730 cases being split into 4 different groups, which is robust, PCDS, mild, and sign. And at the end, we found that with the multi-domain intervention, PCDS is truly a reversible status, that the physical health can be improved, frailty status can be reduced, cognitive function can be improved as well. That is very important, that we did define people who are at risk and are potentially reversible. That's the different domains of the cognitive performance. But to do all the cognitive performance in the community is very labor-intensive work. So we're trying to develop a screening tool based on the annual health checkup in the community. So then we generate a scoring system. If you're having over 4 out of the 14 score with a sensitivity of 70 and specificity of 60 to be PCDS, then we recommend for further cognitive tests to have the validated diagnosis for PCDS. So all those items to construct the scoring system, including older age, people who age over 75, score 3, men, score 3, central obesity, score 1, with slowness or mobility problems, score 2, who had memory issues, score 4, and who has diabetes, score 1. So that is the overall scoring system. And then we are running a very important intervention trial, so that we can see whether the multi-domain intervention have all those multi-domain intervention really change the biomarkers in the serum, in the circulation, or in the neuroimaging. So it is an ongoing trial. We are hoping that by this trial we can clarify whether this neuroimaging biosignature and the serum biomarkers are the candidate for the diagnostic requirement for PCDS in the future. So, at last, I would like to summarize for my talk today. That is, PCDS is really there. And through the epidemiological study, it supports our hypothesis that it is a risk condition, that is the risk for mortality, incident disability, and incident dementia. And there are some specific gray matter deficit in the neural circuit being identified. And there are some special biomarkers, miR29B3P, to link muscle and neurons. And the multi-domain intervention works. And now there can be a potential brain-muscle axis in the unhealthy aging and the PCDS, so that we can change the trajectory of our aging process in the future. Thank you very much. This will be my talk today.
Good afternoon, Argentina, ladies and gentlemen. Thank you, Professor Arai, for organizing this session and inviting me as a speaker. Today, I'm going to share with you our findings regarding the pathophysiology of physiocognitive decline syndrome, which is a phenotype of accelerated functional declines in the elderly. We wanted to evaluate whether people with PCDS had advanced brain age and more severe small vessel disease. As comprehensively mentioned in Professor Liang Gong Chen's talk, we have constructed the criteria of PCDS based on our previous studies. In our previous studies, we have found that physical frailty has heterogeneous clinical and neuroimaging characteristics. Mobility frailty, gait slowness, or hand grip weakness is the subtype that was associated with cognitive impairment. Since cognitive trajectories of physical frailty-associated cognitive impairment is not yet clear, so we consider all cognitive domains to define the cognitive impairment of PCDS. This phenotype successfully defined a substantial amount of target population, and it predicts all-cause mortality and incident dementia in the elderly. Furthermore, we found that it is a good study target to evaluate the pathophysiology of accelerated functional decline in the older people. The present project studied the population from the ELAS cohort, which is recruiting community dwelling persons aged more than 50 years old with no major disease, disable, or dementia. All of them had received comprehensive physical and cognitive assessments and high-resolution 3D brain MRI. First of all, what is brain age or brain biological age? How do we define the brain age? With the same chronological age, some people age faster than the others. So biological age compared with the chronological age is better representative of individuals' aging healthy status. Machine learning models fed with data of neuroimaging features has been developed to predict age. Evidence shows that this measured age or predict age might serve as a biomarker of brain biological age. Individuals with measured brain age older than their chronological age are deemed as having an accelerated or advanced brain age. Studies have shown that these people with advanced measured brain age have poorer age-related cognitive declines and are prone to certain neurodegenerative disease, psychological disease, and mortality. This technique yields a measurement, the brain age gap, the BLOQUE, which is the difference between measured brain age and chronological age. BLOQUE has been used to evaluate how neurological disease interact with the normal brain aging process and to predict clinical outcomes in this disease. Our first aim was to evaluate whether accelerated brain age is involved in the pathophysiology of PCDS. There were 1,193 ELAS participants with eligible brain MRI data included, and we classified them into 4 groups: the robust, isolated cognitive impairment, isolated mobility impairment, and PCDS. There were 198 PCDS people who were older, less educated, and having poorer cognitive functions than the other groups. We then use machine learning fed with the big MRI data of brain gray matter features from another cohort to develop an age prediction model. This prediction model had a well performance to predict the chronological age. Then we apply it to the ELAS cohort. So each ELAS participant would have an estimated brain age measured by this model and a gap between measured age and chronological age. The results adjusting for age, sex, total intracranial volume, and education show that PCDS had advanced brain age compared with the robust MIND and the CIND groups in the total population. And there was a trend of age interaction effect on the association between BAC and MIND. Only in people older than 65 years old, MIND had advanced brain age compared with the robust. Our second aim was to see whether accelerative neurovascular aging is involved in the pathophysiology of PCDS as well. Cerebral small vessels include arterial, capillaries, and venous, which are responsible to regulate cerebral blood flow, blood-brain barrier, and CNS lymphatic system. Small vessel disease developed with aging, and age-related SVD is an important etiology of dementia, gait disturbance, and stroke in the elderly. Brain parenchyma lesions caused by these age-related small vascular pathologies have been used as the disease markers of SVD, and these markers include white matter hyperintensities, LaCun, and microbleeds. There were 734 people with eligible brain MRI images for SVD evaluations. Each participant had a sum of SVD score, which comprised of items of whether a presence of white matter hyperintensity, LaCun, or several microbleeds. And we define SVD as having SVD score more than 1 point. In non-stroke functional preserved and non-demented ELAS population, there were 124 SVD people who were older, less educated, and having more prevalent vascular risk factors. The results show that the prevalence of SVD was different among 4 groups, and PCDS had the highest prevalence of SVD. PCDS was also older and had a trend of more prevalent vascular risk factors, so we performed a multivariate analysis adjusting for these potential confounders. And the results show that SVD was significantly associated with PCDS. The presence of SVD had a higher risk of PCDS than non-SVD, with an odds ratio of about 2. This data led to the preliminary conclusion. PCDS, a clinical phenotype, helps identify who are at risk of dementia, disable, or mortality. Also had accelerated aging in brain gray matters and neurovasculatures. Since PCDS is reversible, the critical point toward unhealthy age. Brain age and small vessel disease involved in its pathophysiology might be the potential treatment targets for healthy aging. I would like to thank to my collaborators from Institute of Neuroscience and Brain Research Center, Aging and Health Research Center, National Yang-Ming Chiao Tung University. Thank you very much for your attention.
Thank you for this opportunity to present our work here. I'm Yukiko Nishita from National Center for Geriatrics and Gerontology in Japan. Today, I will talk about the relationships between frailty, cognition, and regional gray matter volumes by showing our NIRS-LSA cohort data. I'd like to start with a brief introduction of our study cohort, NIRS-LSA. Then I'd like to show you the cross-sectional association between physical frailty and regional gray matter volumes. Finally, I'd like to show you preliminary results about the longitudinal relationships between physical frailty and regional brain volumes using the latest 10-year longitudinal brain data. Now, let me start with the explanation of Nielsen LSA. Nielsen LSA is a longitudinal epidemiological study of aging in our center, NCGG. We randomly selected the baseline participants stratified by age and sex from 40 to 79 years old from the community living populations. The participants have been followed up every 2 or 3 years. From the first to the seventh wave, the Nielsen LSA applied a dynamic cohort study which recruited new participants of the same number of dropouts. Just this February, the 9-wave investigation was completed, and we are currently working on the data cleanup. The Nielsen LSA has many observed data which assess important geriatric syndromes such as frailty, sarcopenia, cognitive impairment, and their factors. Additionally, we collected the three-dimensional brain MRI data at Wave 6, Wave 7, and the recently completed Wave 9. We are now constructing a 10-year longitudinal database of MRI images using these data from 3 time points. As a further study, we are now working on the brain image sharing platform between the Nielsen LSA brain image database in Japan and Iran longitudinal aging study brain image database in Taiwan. Unfortunately, due to the COVID-19 situation, it has been delayed, but we will move forward. Now, I will move on to my main topic, association between physical frailty and regional gray matter volumes. Let me show a brief introduction. Physical frailty makes older people vulnerable to stress. Some studies show that physical frailty and cognitive function affect each other interactively and decline progressively. In addition, many studies showed that physical frailty increases the risk of subsequent dementia, not only for MCI older people, but even for people with higher baseline cognitive performance. And here I'll show the findings of a collaborative study between Nielsen LSA and Dr. Xu at the Kaohsiung Veterans General Hospital on the relationships between working speed, grip strength, and processing speed. The results show that the DSST, that is processing speed, scores declines more steeply in the slow walking or weak grip strength groups than in the normal groups in 10 years. That is, slow walking speed and weak grip strength predict a steeper decline in processing speed in 10 years. Moreover, let me show the latest findings regarding the longitudinal association between change in cognitive function and change in physical function using the newest longitudinal dataset that provides us with a 20-year follow-up. We used multivariate latent growth curve modeling to estimate both cognitive and physical function slopes and examine their association. After adjusting for the effects of covariates and other possible paths, we still found significant and robust associations between the slope of cognitive function and the slope of physical functions. That is, the change in physical function is associated with the change in cognitive function in 20 years. Here, I'll focus on the association between physical frailty and regional gray matter volumes. The research question is, which regions of the brain are closely related to physical frailty, and which frailty component is most closely associated with brain structure? Those selected for this study are the 835 participants aged 65 or older in the sixth wave of the Nielsen assay. We assessed physical frailty using the modified criteria of the cardiovascular health study. All 3D T1 images were processed by SPM8, spatial normalization, segmentation, and voxel-based analysis of the relationship between whole brain and each frailty component. I'll show the main results. According to the results of the voxel-based analysis, weakness and slowness were significantly associated with some regions of gray matter volumes. Weakness is related to the smaller gray matter volumes in the hippocampus, amygdala, and fusiform gyrus. The presence of slowness shows smaller gray matter volumes in the hippocampus, amygdala, fusiform gyrus, insula, and inferior frontal gyrus, besides the cerebellum related to physical function. We think that this is an important result, not only in the cerebellum responsible for physical functions, but also the regions related to cognitive functions and social processes are related to physical frailty. Here, I'll summarize the study. We conducted BBM analysis to clarify the relationships between physical frailty and regional gray matter volumes. Weakness and slowness were associated with brain volume. They were significantly correlated with a reduced volume in the cerebellum, hippocampus, amygdala, fusiform gyrus, inferior frontal gyrus, and insula. Regarding the significant association between the hippocampus and amygdala, previous studies suggested that atrophy of hippocampal and amygdala gray matter volumes predicted cognitive decline. So, weakness and slowness are probably associated with the regions related to cognitive functions. Therefore, from the aspect of the brain structure, weakness and slowness, that is mobility type frailty components, could be useful indices for cognitive frailty. On the other hand, regarding the significant association of the amygdala, fusiform gyrus, inferior frontal gyrus, and insula, this figure shows brain regions associated with the social processes related to misinterpretation of the intent of others, impaired daily social communication, and social withdrawal. For example, the amygdala is related to emotional experience. The fusiform gyrus is associated with face perception. The inferior frontal gyrus is related to voice perception. And the insula is associated with affect sharing. Therefore, physical frailty is likely to link with brain regions associated with social processes involving social frailty. Finally, in this presentation, I'd like to show the preliminary analysis using 10 years longitudinal brain data. Specifically, I'll show the results of age-related changes in cerebellum responsible for physical functions and hippocampal volume responsible for physical functions. Also, I'll show the relationships between physical frailty and subsequent changes in both volumes. The subjects of this preliminary study were 688 participants whose MR image of wave 9 had already been preprocessed and cleaned up. The cerebellar and hippocampal volumes were calculated with longitudinal free server software using 3D T1 MR images. We used linear mixed models for the longitudinal change of the cerebellum and hippocampus, which can adjust for within-subject correlation caused by repeated measurements. This figure shows model predicted 10-year longitudinal change substituting baseline age in 5-year increments. We can see, in contrast to the cerebellar volume, the hippocampal volume seems to reduce sharply over 60 years. However, the differences are not clear because of the different y-axis ranges. Therefore, we estimated the atrophy rates of hippocampal volume and cerebellar volumes for 10 years at baseline age in 5-year increments. As we can see, compared to the atrophy rate of cerebellar volume, the hippocampal volume shows a higher degree of atrophy with aging. That is, decrease of the cerebellum progresses gradually from a younger age, while the decrease of the hippocampus progresses quadratically in old age. And importantly, these figures show intercept and annual changes in cerebellar and hippocampal volume plotted by age in all subjects. As we can see, there are large individual differences in the cerebellum and hippocampal aging. Especially, it might be interesting that as we age, the individual differences in hippocampal atrophy become larger. Therefore, it is important to clarify the factors associated with individual differences in cerebellar and hippocampal atrophy in old age. Here, we try to examine whether each component affects subsequent changes in hippocampal and cerebellar volume. Also, the number of participants was not sufficient to provide clear results. The slowness and weakness were associated with a subsequent steeper decline in hippocampal volume. In relation to the cerebellum, only the main effect of slowness was significant, with slowness being associated with a smaller cerebellum overall. Here is a discussion about preliminary analysis using 10 years longitudinal data. We conducted preliminary analysis to examine age-related change in the cerebellar and hippocampal volume and the relationships between physical frailty and 10-year longitudinal change in cerebellum and hippocampal volume. As a result, decrease of the cerebellum progresses gradually from a younger age, while the decrease of the hippocampus progresses quadratically in older age. And there are large individual differences in the cerebellum and hippocampus aging. And one factor explaining these individual differences might be physical frailty, especially slowness and weakness. In conclusion, the progression of physical frailty, especially weakness and slowness, is associated with regional brain volumes related to cognitive and social processes as well as physical function. And physical frailty, especially weakness and slowness, might longitudinally affect the decrease of hippocampal and cerebellar volume. Future studies are needed to clarify the details, mechanisms of causal relationships. That's all for my presentation. Thank you for your attention.
Thank you for your participation. It's now Q&A time. We had 3 excellent speakers in the symposium talking about the interaction between brain and muscle. So we are waiting for the question. Before we get some question from the audience, I'd like to ask Liang-Gun Chen about the mechanism of PCDS. So you have shown the very interesting data about exosome microRNA, microRNA 29B3P, it is excreted from the muscle. Is that right? And then what is the target of neuron or in the brain? Did you identify the target of this specific microRNA?
Yes, we did. The original process is that we identify several different microRNA in the microsomes from the dexamethasone-induced atrophy of the muscle cell lines. And then we compare those microRNA with the human samples of the sarcopenic patients. And then we identify that the microRNA 29B3P are identical in the cell line study and the human sample. And then we are trying to find out whether this microRNA act on the neurons. So we generate the IDS platform for the normal human neuron instead of the neuroblastoma cell lines. And then we treat those eye neurons with this microRNA and identify that those neurons are experiencing the accelerated aging, the senescence process. And now we're working on the mechanisms that when those neurons are exposed to the microRNA, and it's quite likely that the HIF-1 alpha did play a very active role in the whole pathogenic process. So we are also doing now a randomized control trial, trying to see that if multi-domain intervention really changes those biomarkers to the muscles and the structural images of the brain. So that's the ongoing process. We're hoping to be more clearer about the mechanism from this muscle-brain talk. Thank you.
There are several, similar items or conditions like PCDS. The original one is cognitive frailty, but the original definition of cognitive frailty is very had a little problem. So they try to modify, to or expand, the definition of cognitive frailty. And another group came up with motoric cognitive risk syndrome, MCR. So can you explain the difference between cognitive frailty, MCR, and PCD in terms of the brain muscle interaction?
Okay, thank you. That the overall, I think there is a very strong research interest to be focused on the phenomenon of the dual declines in physical and cognitive function, no matter how you named it. But this phenomenon has attracted very extensive research attentions. And the problem is how to operationally define and identify those people. And I think that the original and the most important purpose to define this category is to identify people who are at risk for subsequent disability and dementia. And it should be at the stage of reversible, with strong reversibility, so that we can prevent disability and dementia at the same time. I think that is the original most important purpose. And then we go back to the definition of cognitive frailty and the MCR, that the cognitive frailty, the original definition is not really feasible in the clinical practice because of the very low prevalence. Even though some researchers has expanded into the potentially reversible and reversible cognitive frailty using different operational definition, but there are still limited studies showing that this definition meets our original purpose. There are only a few epidemiological studies. There's no intervention study, no mechanistic studies. And if we move on to MCR is relatively more evidence-based with more stronger epidemiological support. But one question is their operational definition for the cognitive impairment using the subjective cognitive decline. And studies in Asian countries has shown that those who reported subjective cognitive declines are usually confounded by depressive symptoms. So that is why the PCDS, we would like to, in the mobility part, we measure walking speed and hand grip strength. But in the memory, in the cognitive part, we kind of insist using objective measurements. So although the concept of the three entities are very similar, that highlights the importance of this phenomenon. But we think PCDS are using much better operational definition and with strong epidemiological, randomized control trial, even mechanistic studies to support this operational definition. So I think this is one way to make this phenomenon clearer for the international researchers. Thank you.
Thank you. I think PCD has a lot of evidence in terms of the mechanism. For example, a brain MRI and blood biomarkers compared with cognitive frailty or MCR, I hope. Here we have a question from Davis. These studies were all in people who are well at baseline. Do you think that this may also affect how people with midlife disability or mental disorder can be helped to age better? Lianko, do you have any answer to this question?
So far, no. We included people who are disability and dementia free at the baseline. But our samples are not only focused on the people age over 65. We collect the samples from age over 50. So eventually we do have some mid-age people. And we did find that the mid-age people with PCDS, eventually they are experiencing the same risk for incident disability and dementia. So it is pretty much an accelerated aging process, even though at that time in the brain imaging, there's not yet specific morphological changes. So we're still trying to figure out the potential mechanism and whether this phenomena also can be applied to other entities in the mid-age people. So we're hoping we can expand our research in this part. Thank you.
Thank you. We're basically geriatricians, so basically we are dealing with only older people, not middle-age group at the moment. Yeah, we need to collaborate with other researchers in terms of the study of middle-age group. I have a question to Xiping. So you found the difference between mobility type and mobility type in terms of the white matter lesion and gray matter volume. Is that right? So you found that there's a atrophy of the brain or larger gray matter, white matter lesion in the only in mobility type of older people or frailty. So any explanation about the difference between mobility and non-mobility type to affect the brain structure?
I think on my studies, the findings are all reduced gray matters volumes in mobility frailty and PCDS, but the reduced gray matter volumes were more significantly in PCDS. It is not that significant in mobility frailty. For the DTI data to explore the associations between the white matter integrity and these phenotypes. But maybe Dr. Arai are mentioning the studies about the small vessel disease we just published. In that studies, we really show increased white matter volumes in early stage of
of cerebral amyloid angiopathy, but not in frailty phenotypes. Thank you.
Have you ever tried to see the reversibility of the brain volume or after intervention?
Maybe we should ask Dr. Chen. So after the intervention, do you see the volume changes?
No, it is an ongoing trial. I think we work together in the brain project that we specifically enroll people with potentially PCDS presentations and seeing how rather more stronger frequency multi-domain intervention can reverse the structural brain imaging or the biomarkers. And it is still, I think it is 1 year intervention. We're now in the middle. We just completed the first 6 months, but it's a little bit delayed, because of the pandemic. So we will, I think next year we'll be able to report the findings.
So basically, non-mobility type is associated with cardiovascular risk. So I think non-mobility types seem to have a higher risk for cardiovascular mortality or cardiovascular incidence. Do you know the data to show the outcomes of non-mobility type?
It is relatively difficult because based on the either Framingham Heart Score or the WHO cardiovascular risk assessment, all the participants, basically over 70% in the beginning, is at the low risk group. So it is difficult. But from other national representatively cohort, we did identify PCDS people. They have higher risk for all-cause mortality and cardiovascular mortality. So that is another supporting evidence, not from our cohort. Our cohort, they are too healthy.
Okay, I have a question to you, Kiko. You have shown the atrophy of cerebrum and hippocampus. The volume is going down more rapidly in the hippocampus, right?
Yeah.
Did you see the association between the atrophy of cerebellum and hippocampus?
Thank
so
you
the
for
same person have the same tendency or independent?
It's really important point, but we haven't examined yet. But yeah, maybe its interaction is really important. So we'll examine. Thank you.
Please, thank you. Okay, we are almost time. Thank you for your participation. This area is very hot topics in the field of frailty. And as we mentioned, the definition of cognitive frailty is changing, and still the consensus is not reached. So as far as I know, there are 3 kind of definition of this area: cognitive frailty, MCR, and PCDS. We need to, have more discussion on the this area. So thank you very much again for your participation, and looking forward to seeing you in person. Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you.
Yeah.